I'm Dr. Aldo Montano. I'm one of the hepatologists at the University of Alberta. And welcome everybody to the Alberta Transplant Institute seminar series. Before we start, I would like to give a land acknowledgement. The University of Alberta acknowledged that we are located on Treaty 6 territory and respect the histories, language, and cultures of First Nations, Métis, Inuit, and all First People of Canada, whose presence continue to enrich our vibrant community. Thank you to Paladin for their support to the Alberta Transplant Seminar Series. And today, I'm honored to present Dr. Dean Karvellas as our speaker. Dean is a professor of medicine in critical care medicine and gastroenterology and hepatology at the University of Alberta. He's also an adjunct professor in the School of Public Health Science, and he has been an attending intensivist in the Gardner King General System Intensive Care Unit since 2009. Dean is involved in the liver transplant program, and also he's one of the hepatologists in our liver unit. Dean is a co-investigator in the NIH-funded liver transplant in the NIH-funded United States Acute Liver Failure Study Group, and he has co-chaired multiple liver failure guidelines through the Society of Critical Care Medicine and the American Association for a Study of the Liver. He is an editor of the Journal of Hepatology, that is the highest impact factor journal currently for hepatology, and also to the American Journal of Transplantation. Dean is really prolific. He has over 140 publications in several high impact journal factors journals, and he has main interest in acute liver failure, acute-on-chronic liver failure, liver transplantation, and extracorporeal liver support. So it's my pleasure to present him, and he will be giving a talk in liver transplantation in acute-on-chronic liver failure. Thank you, Dean.
And it's a real pleasure to speak to everybody today on this topic of liver transplantation and acute-on-chronic liver failure. First thing is I don't have any conflicts to disclose, nor will I be discussing any off-label use of any drugs or devices. So the main objective of this talk, and I realize that I'm speaking to a varied group from a variety of different both clinical and academic backgrounds today, is kind of to go over an understanding of the definition of acute-on-chronic liver failure. And primarily we're talking about patients with cirrhosis with multi-organ failure. I'm going to talk a little bit about management of specific organ failures and ACLF in terms of bridging these patients to transplant, to just give you a little bit of insight of how we try to kind of salvage these patients in the ICU setting. Examine the impact of critical illness on post-transplant outcomes and complications, and this tends to be a real challenge for us, particularly when we try to define a potential window for transplantation, and also review the challenges in determining futility in ACLF regarding when a patient is too sick to transplant. So in a nutshell, many different groups have been kind of wrestling with a definition of acute-on-chronic liver failure. And primarily this is to make sure that we're comparing equivalent patients in different parts of the world. And really kind of the most kind of simple consensus kind of statement about this is a patient with decompensated cirrhosis, either secondary to superimposed liver injury or some kind of systemic precipitant, culminating in multi-organ dysfunction with an associated increased mortality at 3 months. And in terms of what this multi-organ dysfunction syndrome is, it can occur with a variety of different precipitating events. There often tends to be a predictable pathway, irrespective of the inciting event. Patients can get hemodynamic alterations. They can develop acute lung injury and respiratory failure. They can develop significant hepatic dysfunction or GI dysfunction. They can develop AKI, which is one of the other main reasons why patients are transferred to the intensive care unit. They can develop neurologic failure. And in late stages, they can actually develop marrow suppression, which can put them at very high risk of developing infection. So there are, as mentioned, a couple of different definitions depending on the different parts of the world. And for the purposes of this talk, I'm primarily going to be using the most widely used definition, which is the European CLIF definition, which, as you can see, organ failures are really kind of derived from 6 different domains: hepatic, renal, neurologic, coagulation or hematologic, circulatory, and respiratory. And this really was kind of born out of the SOFA score, which had been widely used in critical care units since the 1990s, and it's the easiest to understand. So in terms of the types of triggers of multi-organ failure and cirrhosis or acute-on-chronic liver failure, there is some variation depending on what part of the world you're from. The canonic, which was a European study, the predominant precipitants that could be identified were bacterial infection or ongoing alcoholism. Where if you go to other parts of the world, like Southeast Asia, where there is a large prevalence of hepatitis B, it tended to be Hep B reactivation. As mentioned, this European CLIF definition kind of was based out of the canonic study, which was a large multi-centered study that was done through the CLIF consortium in Europe. Richard Moreau was the lead on this back in 2013. And essentially what they did is they evaluated 1,343 hospitalized decompensated cirrhosis patients, of which 450 developed multi-organ failure or acute-on-chronic liver failure. And from this study, they were able to classify patients essentially based on the number of organ failures, as you can see here. And the simplest way to think about that is that you were an ACLF1 if you had one organ failure, with the proviso that if it was neither renal or neurologic, that you had to have at least some mild encephalopathy. ACLF grade 2 was 2 or more organ failures, and ACLF 3 was 3 or more organ failures. And as you can see here, in an effort to try to stratify patients with different prognoses, they were able to kind of show that, for example, if you did not have ACLF, your 90-day mortality with decompensated cirrhosis was around 10%, where if you had 3 or more organ failures, it was approaching 80% at 28 days. So one of the other kind of important nuances of coming up with this type of a definition is that many of us are aware that the currently used scores that we use to stratify patients on the transplant list, such as MELD, tends to underestimate the risk of death in patients with acute-on-chronic liver failure. And part of the reason for this is that MELD really primarily represents, liver dysfunction and renal dysfunction. And this was a nice study that Vinay Sundaram published back in 2019 in Gastroenterology, that essentially what he showed when they looked at mortality, that an ACLF grade 3 patient that even had a MELD of less than 25 had almost a 50% mortality at 1 year. So from a practical point of view, when do we take these patients to the intensive care unit for critical care support? It's primarily for circulatory management for shock, management of respiratory failure, hematologic support, and renal support in somebody with acute kidney injury. So there are many well-known circulatory abnormalities that have been described in patients with cirrhosis that tend to be exacerbated when they develop circulatory failure. And we know classically from hepatocellular dysfunction and portal hypertension that there is an increase in circulatory levels of vasodilatory molecules such as nitric oxide, also related to portal systemic shunting, which can lead to both splanchnic and systemic vasodilatation. And what this will lead to is a decrease in overall systemic vascular resistance. And initially, to maintain circulatory blood volume, patients can compensate by increasing their cardiac output. And classically, if you do a bedside echocardiography on patients with cirrhosis, they generally tend to be hyperdynamic by increasing this cardiac output. However, this will come to a point that the SVR drops so much that you develop relative arterial hypovolemia, and you get upregulation of secondary neurohormonal pathways such as the renin-angiotensin system and antidiuretic hormone. And this is one of the things that tends to lead to hyponatremia in patients with very advanced liver disease, which tends to be a precursor towards developing hepatorenal syndrome. Another thing to note is that having this hyperdynamic circulation with low afterload is often it can mask significant cardiac issues, including cirrhotic cardiomyopathy. And this is a well-described phenomenon, and it tends to be a challenge for us and something that we need to assess very carefully in terms of decisions to proceed with transplant. We know that patients with cirrhosis can develop a blunted contractile responsiveness to beta-adrenergic receptors through a variety of different mechanisms. And also there can be altered diastolic relaxation, which will not necessarily be just reflected in an assessment of systolic function. And you can also get electrophysiological abnormalities. And this often occurs in the absence of other cardiac disease. And this is a phenomenon that's well described in the anesthesia literature. And for this reason, in general, if you have an ejection fraction of less than 50%, which doesn't sound that terrible, this tends to be a hard stop sign in terms of proceeding for a liver transplantation, because we know when we put the new liver in and we tighten up the systemic vascular circulation, that they can develop heart failure. So in terms of assessment of volume status, this tends to be very challenging in patients with cirrhosis, partly because they have a lot of third spacing of fluid. Generally, our approaches now involve using dynamic measures. We've gone away from just things like pulmonary artery catheters, and we're using more kind of dynamic bedside tests such as echocardiography. And there's a larger kind of population of critical care providers that have developed expertise in bedside echocardiography. And we actually have a large group here at the University of Alberta. And one of the benefits of this is that you can get a real-time assessment of both left and right ventricular function, and furthermore responsiveness to fluid. One of the things to mention is that one of the challenges we face is trying to avoid volume overload, because for many different conditions that may afflict a patient with cirrhosis, for example, SBP or hepatorenal syndrome, first line often tends to be giving the patient significant amounts of albumin and volume. But we know that there's an evolving body of literature that shows that volume overload can affect a variety of different organs with deleterious consequences. And in essence, volume in itself is a drug like anything else. And one of the biggest challenges that it may exacerbate is a phenomenon known as intra-abdominal hypertension, and specifically intra-abdominal compartment syndrome, which can make a critically ill patient very difficult to ventilate or may affect their renal function. So, and one other cautionary tale is that, there are several indications in patients with cirrhosis to use albumin. Transfusing albumin to a trigger serum level has been actually demonstrated to be associated with harm. And this was the recent ATTIRE study that was published in the New England Journal. And I just want to highlight this because this tends to come out in many different studies and publications of patients with both cirrhosis and ACLF, where what they found was in the group that was randomized to albumin infusion, targeting a serum albumin of 30 grams per liter, that not only were there no benefits with this, but those patients developed more complications, including primarily pulmonary edema. So kind of the most important aspects of the management of shock or circulatory dysfunction in ACLF is kind of early baseline assessment of volume and perfusion status and cardiovascular function. We will use things like balanced crystalloid solutions like plasma, light and Ringer's lactate. Albumin, if there is evidence of SBP or hepatorenal syndrome subtype of AKI, or for large volume paracentesis, but it's not used as a primary resuscitation fluid. Norepinephrine is a cheap vasopressor that we tend to use as first line, and normally we'll target a mean arterial pressure of 65 millimeters of mercury, with probably the exception being if they've got acute kidney injury, where we'll target a higher mean arterial pressure. And one thing to mention as well is that relative adrenal insufficiency is probably under-recognized in these patients, and we do consider the use of hydrocortisone in patients with refractory shock. One of the biggest precipitants, as mentioned before, of ACLF is sepsis or bacteremia. And there are many different reasons why patients with cirrhosis in general are in an immunocompromised state. We know that there tend to be losses of the tight gap junctions in the gut, leading to bacterial translocation. And in the setting of cirrhosis, where you can develop portosystemic shunts, often there can be shunting of bacteria that will bypass the reticular endothelial system and some of the patient's natural defenses. And you can end up seeding sterile areas such as the peritoneum, which leads to spontaneous bacterial peritonitis, and furthermore, the bloodstream, where you can develop bacteremia. And both of these are associated with deleterious consequences in cirrhosis and ACLF. This is an old study that we did, but it really kind of highlights that if you review the critical care literature and the surviving sepsis guidelines, while there is a lot of equipoise around a lot of the other kind of suggestions and recommendations, really early appropriate antimicrobial therapy is the most important thing. And I just highlight that in this population of cirrhosis patients with septic shock, that each hour in delay of appropriate antimicrobial therapy increased the odds of death by almost 1.9 times. Um, uh, One thing that tends to be a challenge with regards to going ahead with transplant is actually respiratory failure, as this can be a big issue for anesthesia to get somebody through an operation, particularly where they're lying supine for several hours. And I just want to highlight that there are respiratory complications that are specific to cirrhosis and ACLF, such as a hepatic hyperthorax, hepatopulmonary syndrome or shunt, and alpha-1 antitrypsin. And then there are standard complications that can make the management of these patients very difficult, such as pneumonia or pulmonary embolus, as certain patients with cirrhosis can actually be hypercoagulable. I wanted to highlight here that there really isn't a lot of literature on the best way to manage these patients from an oxygen point of view that's specific to liver patients or to ventilate them. But generally, this is based on Boro literature from the general critical care literature, and we will employ a lung protective strategy. And what we mean by that is that we use a low driving pressure with a low tidal volume to avoid precipitating barotrauma, but we'll use a high positive end expiratory pressure to keep the alveoli open. The only challenge one can run into in a patient with ACLF is that these patients may be very fluid responsive, and often high peaks can cause hypotension. So this is one of those things where often we're faced with dealing with the frailest organ system, whether that's is it shock, is it respiratory failure, or is it acute kidney injury? Speaking briefly about neurological failure, one of the biggest challenges in terms of coming up with new drugs for hepatic encephalopathy is that there are so many other confounding factors that can also cause altered mental status in a patient with cirrhosis and by extension acute on chronic liver failure. And I just kind of highlight this here, that it's not all hepatic encephalopathy. And certainly in the patient that we're working up for transplant, we will try to rule out other causes of altered mental status. And one of the important implications is the thinking is with hepatic encephalopathy, this is generally something that will resolve with transplant, but we know that there are other things that may not improve with transplant. While kind of the bread and butter recommendations are ICU transfer for patients with a GCS of less than 9 or a grade 3 or 4 hepatic encephalopathy by the Westhyman criteria, where this is something where early intubation to protect the airway may prevent an aspiration, which will help somebody stay on the transplant list and avoid a pneumonia. In terms of the workup for hepatic encephalopathy, doing CT scans on the first presentation may have relevance, but in somebody that's had multiple episodes of HE, probably does not add anything to your management. One thing I want to highlight as well on the ward, we tend to use drugs like lactulose and rifaximin. One of the issues with lactulose is that this can cause bowel distension. So we tend to use drugs like or medications like polyethylene glycol in the ICU because this has a lower risk of exacerbating ileus or abdominal distension. When we have to sedate patients on mechanical ventilation, we will use short-acting drugs like propofol and dexmedetomidine, which is a newer drug because they don't exacerbate hepatic encephalopathy and they tend to be short-acting, so we can turn them off, and within 15 or 20 minutes, we can do a reasonable neurological assessment. When looking at acute kidney injury, this tends to be challenging because it can sometimes be very difficult to discriminate different causes of AKI that I highlight here. And the other thing that's important is that AKI may be multifactorial. One example being a patient with NASH cirrhosis that has also diabetic nephropathy can develop a true hepatorenal physiology, which tends to be a severe form of AKI in somebody with very advanced liver disease, where our previous understandings of this is that we couldn't diagnose HRS in the presence of proteinuria, but what we're becoming a little bit more nuanced with this, knowing that you can have multiple different coexistent etiologies. If you look at different case series from different parts of the world, these are primarily from Europe and North America, you can see that the prevalence of specifically HRS really varies from anywhere from kind of 18 to 40%. And as I'll kind of go through the next couple of slides, this does have significance with regards to the decision to list for transplant and also the specific management that needs to be offered. The one benefit nowadays is that some of the definitions of severity of AKI have been harmonized from the International Club of Ascites to fit with some of the other definitions that are from the critical care and nephrology literature. So the new ICA kind of classification of stage 1, 2, and 3 AKI are fairly similar if you look at the KDIGO classification that's from the nephrology literature. And the simplest way to think about this is stage 1 AKI is an increase of greater than 1.5 times baseline in creatinine. Stage 2 is anywhere between 2 to 3 times baseline. And stage 3 is greater than 3, or the requirement for renal replacement therapy. And if you look at multiple studies that have been published since then, generally this tends to stratify patients into different categories with different potential for recovery. I mentioned before that etiology can have a significant impact, and I highlight this study from 2011 from Spain, where what they demonstrated is that even though a minority of patients with AKI admitted to the Barcelona clinic had true hepatorenal syndrome, only 13%, in the absence of liver transplant, they had the highest mortality of 85%. And in the absence of better biomarkers, generally HRS occurs in patients that are hypotensive, they're sodium avid, so they'll have a low urine sodium, and they tend to have very advanced liver disease and tend to be hyponatremic. One of the rationale for the higher mean arterial pressure that I mentioned earlier, because we know that these patients tend to get vasodilated when they develop hepatorenal syndrome, is use vasoconstricting agents and target a higher mean arterial pressure to increase the systemic vascular resistance. And this is an older study from 2011, but it really demonstrated that a MAP increase was needed to increase renal perfusion and achieve a benefit in renal function. And this was kind of further exemplified by the two of the recent studies looking at terlipressin, which is a vasopressin analog. Well, we don't have this drug in Canada yet. It's been approved in Europe for almost 20 years and was finally just approved in the fall by the FDA. So we're hoping that we'll likely have this drug in Canada. It is a drug that can be given in bolus form every 6 hours and can also be given in the ward setting. One of the reasons why it initially wasn't approved in North America is that the original studies done by Senyal back in 2009 didn't demonstrate a mortality benefit. But as I previously mentioned, these are patients with very advanced liver disease. And often one of the biggest confounders for survival is actually transplant. But what the Boyer study and then the confirmed study did last year was what they demonstrated is that those patients that had improvement in renal function, which the terlipressin group had significant higher numbers of resolution of HRS compared to the standard of care arm, was that those patients that had renal recovery had longer short-term survival, which likely led to a higher probability of either getting a graft on the transplant list or surviving long enough to go to rehab to get on the transplant list. In the absence of terlipressin, which we're hoping to have in Canada probably within the year, the second-line treatment is norepinephrine, and this is something that we unfortunately have to use in an ICU setting, and we're hoping in the future to use terlipressin on the ward. You can see from this systematic review that norepinephrine likely is non-inferior, certainly, to vasopressin, although there may be some theoretical receptor benefits that you might get with specifically the V1 receptor with terlipressin. With regards to when to initiate renal support, this is where there are probably more questions than answers. I kind of refer you to the most recent publication, what's called the START AKI study that the chair of critical care, Sean Bagsaw here, was the first author. And really what it showed is in the general critical care population, there was no benefit to accelerated renal replacement therapy, which meant that we did it at stage 2 AKI versus stage 3. And we'll highlight that there was a subpopulation of about 320 patients that had liver dysfunction. So we really, at this point, don't know, when the optimal timing to initial renal replacement therapy. There is the question of what modality do we. Generally, we tend to use continuous modes because they're gentler on blood pressure. So for somebody who's on vasopressor support, continuous modes like continuous venous hemofiltration or hemodiafiltration are your two best options. You may be aware that most renal replacement therapy circuits need some form of circuit anticoagulation to prevent clotting. With a simpler circuit like hemofiltration, often we can get away without giving anything. But in some cases, you might have to give somebody citrate, for example, even though we know that for long exposure to citrate in somebody with ACLF or cirrhosis, you can develop citrate toxicity. So it's just something to be aware of. For some of our kidney renal transplant specialists in the crowd, one of the questions becomes, when would you consider somebody for a combined liver kidney, as this tended to be based on a lot of consensus discussion up until a few years ago, when this really elegant study from Formica and colleagues was published in the American Journal of Transplant. And really the idea here was discriminating somebody that had hepatorenal syndrome that was dialysis dependent, where there was potential for renal recovery, versus somebody that had true ATN, where there was really no potential for renal recovery. And they used a UNOS definition of either being on dialysis for 6 weeks or having a GFR of less than 25 mils per minute for 6 weeks, or a combination of the both. And when they looked overall at the UNOS registry, what they demonstrated was that if you met this criteria for what they called renal failure, the 6-week mark, you actually had a survival benefit having a combined, or whether that was simultaneous or sequential, with a liver kidney transplant versus getting the liver alone. And interestingly enough, if you didn't meet this mark, potentially those patients that got the additional kidney as opposed to the liver actually had a statistically significant trend towards harm. So really, this is one of the first, we used to talk about 6 weeks to 2 months of being either on renal support or having AKI before considering the kidney. It's nice to actually have kind of a robust evidence-based definition. One of the things I will mention where there may be a benefit of early renal replacement therapy is conditioning somebody for a liver transplant, because there can be a lot of metabolic and hemodynamic challenges in terms of going into the operating theater. And this is one of the reasons why we actually consider in our center actually running renal replacement therapy during liver transplant. And the rationale for this is that we know that there are significant physiological derangements during transplant, including lactic acidosis, which you get from clamping of the large vessels during the anhepatic phase. You can develop hyperkalemia after you reperfuse a donor graft that's been on cold storage. And also there's hemodynamic instability and coagulopathy requiring blood products. And in those patients that have AKI or are oliguric, they may not be able to mitigate all of these metabolic changes. So a couple of years ago, the senior author on this was Sean Bagshaw, we did a pilot study of intraoperative continuous renal replacement therapy during liver transplant. And I present this primarily as a cautionary tale. It was a very difficult study to do. And as you can see here, after kind of screening almost 244 patients, we were only able to randomize 32, of which 17 were randomized to standard of care. And of those, 10 actually crossed over to receiving CRRT during the operation, where there was a preset list of criteria. And these were primarily related to fluid overload and hyperkalemia. And if you look at this in an intention or a per protocol fashion, where we look at people who actually got CRRT, you can see that there wasn't really a whole lot of difference in most of the primary outcomes. And I think it just kind of highlights, number one, that this is a very difficult technique to study. Where there probably is equipoise is whether we should just, treat these patients very aggressively with AKI prior to transplant, where we drive down the potassium, we take off fluid to dry them out a little bit. And those patients that have some urine output probably can get through an operation without renal replacement therapy, but potentially those patients that are truly anuric with AKI prior to liver transplant may benefit from intraoperative renal replacement therapy. Taking it a step further, there has been interest in not just renal replacement therapy, but other forms of blood purification in acute on chronic liver failure, using techniques such as albumin dialysis or albumin-based blood purification techniques. And this is just really a slide that just kind of shows you the underwhelming data that we have to this point. So a couple of different devices have been studied in ACLF. And while we are able to improve biochemistry in these patients and remove protein-bound toxins such as conjugated bilirubin, there really hasn't been a device to date that has shown a mortality benefit in ACLF. And probably future studies going forward will really look at these types of technologies potentially as a bridge to liver transplant and not a destination treatment. So I just going to highlight again that you will see people use the CLIF ACLF score, which is based on the canonic study. You can download this on the web. The nice thing about this nomogram is it gives you a score out of 100. I do want to highlight that while a lot of this data I've presented to you tends to be fairly pessimistic, ACLF can be dynamic. And about 40% of patients that we admit to the ICU will improve by at least one organ failure. And that can have a significant impact on post-transplant outcomes. So when we look at kind of the crux of the matter in terms of liver transplant in a group of very high-risk patients, we're aware that we're using a scarce resource, and that, you know, the idea of distributive justice and fair allocation, that while we want to maximize donor patient life years, we tend to transplant the sickest patient first, certainly with liver transplantation. And while there is some debate in the literature about what is minimal accepted utility post-transplant, most centers kind of agree on this 50% survival at 5 years. So there are many factors besides multi-organ failure that impact liver transplant utility, such as medical comorbidity. Sarcopenia is a big one, and the challenge with loss of muscle mass is it doesn't tend to really be captured in most of the prognostic scores that we use. And obviously there are donor factors where if you use a marginal graft in a sick patient, often it can lead to a poor outcome. So in terms of overall transplant outcomes in ACLF, I want to use this study that we did back in 2013 as a schematic. And initially when I presented this data a couple of years ago, I got a lot of people scratching their heads. This was data looking at the five biggest transplant centers in Canada where ACLF patients are transplanted out of the ICU. And if you look at the outcomes in those patients that received a transplant, the outcomes actually look pretty good. You had a 90-day survival of almost 84%. And at that point, we were using the SOFA score as a score out of 24. If you looked at the SOFA score on the day of transplant, it really didn't discriminate between those patients that were alive and dead after transplant. And this might seem strange, or the fact that these outcomes might seem quote unquote too good. But the reality is that really where we lost a lot of these ACLF patients was on the wait list, where, you know, almost 106 of them died waiting for a transplant. And there was a significant difference in terms of SOFA and MELD. And if you look at most of the scores going forward at the number of organ failures, probably highlighting that in terms of when we talk about the counterfactual, we don't know how the people that died on the wait list would have been done with the liver, because some of these patients, it was a human decision to delist them. And some of them, it was based on the unsupportability of them, but likely they would have done poorly. So this is kind of one of the first studies that highlighted that maybe waitlist mortality is actually probably the more important metric that we should be looking at. This kind of phenomenon was actually reproduced in data in Europe and also in the US. And this is a study from Flo Artrou from France, where he showed that if you looked at the winners, if you will, the people that got grafts, you know, even ACLF 3 patients at a year, that these were patients with 3 or more organ failures, still had a 1-year survival of 84%, which sounds quite good. But it's really, when we look at this study by Tulevath, looking at the UNOS literature, it's kind of the other side of the coin, and it raises this question of, should we be treating transplant as an intention to treat, where that the time zero is actually when you're listed for transplant? Because what they showed here is that you know, waitlist mortality went up exponentially with the number of organ failures on the transplant list, and the number of ACLF patients that actually received liver transplant through UNOS was actually quite low. And in those small number of patients that did, so for example, only 1,000 patients out of 90,000 got a liver with 5 or 6 organ failures. Yes, in this selected population, they did actually pretty good with the 12-month survival of 80%. But as we mentioned, this selection bias really probably tells us one way of thinking it is that we're likely doing a good job as clinicians in terms of delisting the worst of the worst. And this is probably something that's necessary. One thing that has come out also of the UNOS registry that Vinay Sundaram published later in this paper in JHEP is that when we're looking, even though at these kind of selected favorable outcomes, that those patients that come in with 3 or more organ failures, that with ICU support, if we can stabilize them and get them down to 0 or 0 to 2 organ failures, they tend to have better outcomes, or outcomes that approximate those patients without ACLF, as you can see by this line here. And to kind of take this a step further, 1-year mortality is not the only thing to be thinking about, because in reality, a lot of things really need to go bad for a patient not to make it to a year. A lot of patients, you know, they may be in the ICU for 3 months and have a tracheostomy. They may have to go back to the OR for repeat takebacks. And this kind of was highlighted in this the model study that was recently published. It's a North American consortium, including our center here, where what Vinay Sundaram was able to demonstrate that with increasing grade of organ failure, certainly with ACLF3, it led to longer post-liver transplant stays, which we see very commonly, longer ICU stays, a longer time on dialysis, and a higher 30-day readmission rate. So there is a price to be paid from a health services point of view that these ACLF patients, even though they may be alive at a year, they take up a lot of resources. So at this point, because of these biases in the literature that may be appropriate that have highlighted, it's really hard to come up with a cue card or a set of criteria to come up with who is really truly too sick to transplant. And we had this kind of Delphi panel that tried to kind of tackle this recently. And as you can see here, a lot of the recommendations that came out of this were actually very vague. One example being, pressors greater than 1 mic per kilo per minute of norepinephrine. I don't remember the last time I had a patient on this much pressor, so it doesn't really help us because it's not really a metric that will help us in terms of kind of delisting somebody, if you will. The acute lung injury is probably important because a PF ratio of less than 150 probably identifies a patient where you're not going to be able to get them through the operation and get them successfully transplanted. So if you look at the current studies of liver transplant and ACLF to date, there are many unanswered questions. There's as mentioned, a lack of intention to treat results from the time of waitlisting. And at the end of the day, from the patient's point of view, whether you die on the wait list or you die after transplant, it probably doesn't have a relevance. Really what you want to know is, at the time of listing, what is my chance of having a successful outcome with transplant? There are questions about best organ allocation systems. That are some of these patients being underrepresented by the current MELD system? Are there objective limits to define a futile transplant, which it's very hard to come up with this from retrospective studies? There are questions about the appropriate use of donor organs and which types should we be using DCD organs in an ACLF patient, for example, if they're higher risk grafts. And also questions about long-term post-transplant survival rates and the impact of quality of life, because we know that these ACLF patients tend to get a lot of complications after transplant. And also the question about resource utilization in performing transplant. So just for your reference, there is a prospective observational multi-centered multinational study called the CHANT study that's been run through the Cliff Group, and we are a center here in Edmonton. And this is for reference is an observational study, but part of the idea is to try to answer some of these questions with good quality data. And the idea is certainly for ACLF grade 2 or 3 patients to essentially enroll them in the study and then observe them as they're on the transplant list and follow their outcomes, whether they successfully get a transplant or not, and what their kind of post-transplant outcomes are, compared with a group of patients with 0 or 1 organ failures. And really, we're kind of interested in what this data will show above and beyond the current retrospective literature that we have. Primarily, this is to look at 1-year graft and patient survival rates and after liver transplant, particularly in patients with ACLF grade 2 or 3 at the time of transplant, but also to look at a variety of these different secondary endpoints that kind of serve as the current knowledge gaps in the literature with regards to transplant and ACLF. So to summarize, acute-on-chronic liver failure is cirrhosis with multi-organ failure. Sepsis tends to be the largest driver of ACLF, and early appropriate antimicrobial therapy improves outcome in ACLF. Regarding circulatory failure, we perform early baseline assessment of volume and perfusion status with dynamic modalities such as bedside echo. We try to avoid fluid overload, and we tend to use norepinephrine as a first-line vasopressor. With regards to treating respiratory failure, we employ a lung protective strategy in ventilated patients, and we consider both hepatic and non-hepatic related causes of acute lung injury. With regards to acute kidney injury, vasoconstricting therapies are associated with improved outcomes or reversal of HRS-AKI. And generally, those responders to vasoconstricting therapies have better outcomes. And we hope with the advent of approval, hopefully of Health Canada, for terlipressin, that we'll be able to use this more widely on the ward. More studies are required regarding optimal timing and modality of renal replacement therapy and other quality-related factors such as circuit anticoagulation in ACLF patients. And while it is unclear whether preemptive renal replacement therapy immediately before transplant or intraoperative CRRT is better, consider the patient specifically if they're oliguric or anuric, and certainly if they're fluid overloaded or hyperkalemic, it may be best to run them on CRRT before going to the OR. Regarding prognosis in ACLF, probably the most widely used score is the CLIF-C ACLF score. But just remember that this is correlating outcomes in the absence of transplant. And finally, when discussing futility with transplant, waitlist mortality is likely our best metric. We need to consider this as an intention to treat, where really time zero is when the patient is listed for transplant. And hopefully we'll have more granular information with the upcoming CHANCE study. And I just wanted to conclude by saying that this guideline that we've been working on for the last year and a half, the ASLD practice guideline on the management of ACLF, will be coming out early in the new year. And I refer you to the ASLD website. Thank you very much, and I'm happy to answer your questions.
In the meantime, Dean, so at this moment, from a clinical point of view, if we are going to consider waitlist mortality as the main indicator, so do you consider like patients who are actually having like a stage 3, stage 4, are they need to be discussed in a multidisciplinary team and basically consider that only a few of them will continue being candidates for transplant?
I think it's a good question, but I think although the bigger thing, it's not just for us as clinicians, it's for the families, that we probably emphasize to them that if you're listed like as a status 4 as an ACLF patient, that one of the main issues is that that we're honest with people and we say that there's a high probability that you could die on the wait list, and that just listing you for transplant doesn't imply a favorable outcome. And I know that there's a lot of this discussion around framing things to patients as the best case and worst case scenario. And I think really where this comes in, that we need to be kind of honest that even if you get transplanted out of the ICU, you're going to have a rocky road, certainly if you've got 3 or more organ failures. So I think also it comes back, as you know, there's a lot of variety. From some centers are very conservative in terms of not transplanting people with multi-organ failure. Some centers tend to be very aggressive. And to be fair, we've been quite aggressive with these patients. But I think it just kind of involves looking at this kind of with a wider lens in terms of, what are our, number one, what are our minimally accepted, metrics with this? And I think this warrants more investigation. And then secondly, being very honest with patients, saying that this is going to be a rocky road if we get you through this, and just kind of being upfront with that. Yeah,
well, thank you, Dean. There is a comment. So Murray Wilson is mentioned, great presentation, and keep that research project going, and thank you. And then there is a question from Simon. So Simon, please.
Hey, Dean, thank you. Great talk. I just had a quick question for clarification or my understanding. So you mentioned that an ejection fraction of 50% or less would be a hard knockout criteria for a liver transplant. That sounds pretty radical to me. And I was wondering if that is first correlated with a respective high mortality compared to your many other risk factors that you have. And second, how big is the proportion of patients that you will rule out by that? Because that sounds like a very high threshold.
So Simon, that's a very good question. And it's one of these things that's actually been well published in the transplant anesthesia literature. And the rationale behind this is because of this hyperdynamic circulation. Probably these patients have very little afterload, or liver failure is one of the biggest afterload reducers there is for somebody with congestive heart failure. So one of the issues is that their true ejection fraction probably isn't 50% at all. It's probably 35 to 40%. And we've had patients that, I can remember one patient that went in with an EF of 45% that ended up on ECMO after transplant, because once we put the new liver in, and you increase the venous return to the right heart by 25%, and you tighten up the SVRI, it can lead to significant deleterious consequences. So this is well described in the literature. But really what we're getting at is that 50% is really not 50%. It's probably significantly less.
I don't see any comments, but Dean, really interesting that terlipressin is coming to Canada. So I guess I have a question for you. How do you envision the use of terlipressin? Because in my way, sometimes we tend to overuse, like for example, midodrine and octreotide in many patients that maybe they do not satisfy criteria for hepatosplenic syndrome. And also one concern I have is that obviously the improvement of these patients sometimes has to be with the integral management that they receive in the intensive care unit. So have you guys think about how, if you are going to assess those patients to give recommendations? I know that you are always super busy, but how do you envision that?
It's a good question. I think, first of all, this is a good thing because I think one of the biggest gaps we have is in the ward setting is what do we do with these patients? And although, as you know, as well as I do, midodrine and octreotide are not great. The idea behind terlipressin is that even though it is a vasoconstricting agent, it can be used in a ward setting. If you look at the kind of warning that's going to be on the label, they said, use with caution in patients with ACLF grade 3 or with respiratory dysfunction. And that was because of the confirmed trial that came out recently. But in reality, if you look at the patients in the study, it was because many patients were referred from another center and they got a ton of albumin. So the reason for the respiratory dysfunction was probably fluid overloaded. The bigger thing is, I think, to start with, as you said, it's probably best to use this maybe in a finite number of places in the hospital. So you pick 1 or 2 wards, so maybe 5C3 and 5C4, you pick the 2 GI wards. You train, a group of nurses to say, we're going to be using this drug. It's 0.5 to 2 milligrams every 6 hours IV. They're even talking about a sub-Q preparation as well. And probably the other thing that's come out of most of the studies is that if you wait till the creatinine is more than about 400, it doesn't work. And, obviously one of the cautionary tales of the pandemic is that people have been afraid to consult ICU because of all these COVID patients. And we've ended up getting called in patients when their creatinine's already 400 and it's not 230, when probably these drugs may have benefit. So I think the positive things that are going to come out of it is we'll probably use it early. We can use it as an intermittent bolus. We can probably use it on a couple of wards in the hospital to gain expertise and comfort. And then it might be something where we have a critical care outreach, a MET physician, where you just may make them aware that we've got a patient on terlipressin. Would you mind seeing them or keeping an eye on them? And that way we keep an eye on things. And then the benefit for us in the ICU is we're getting terlipressin failures rather than midodrine failures.
Yeah. No, really, really interesting, and yeah, no, that's a great idea. There is also a comment from Lori West. She's saying terrific talk, and thanks for the detailed overview, Dean. And I don't see any more hands, and I don't see any more comments in the chat. So I guess yeah, everybody's just saying that it was an excellent talk, Dean, and thank you for your excellent presentation, and congratulations for all your achievements that you presented during this talk. So the closing remarks is that next week, the Alberta Transplant Institute seminar, we are pleased to host Dr. Susie Berhout and Brad Messick presenting art-based research and sensory methods in transplantation. Can friction move the field? So the link is in the chat box. So we hope that all of you have a chance to join us in our next ATI seminar. So thank you all of you for attending. And again, thank you, Dean, for an outstanding presentation. Have a great day.